Hi everyone. In today's video, we are going to review hypertension, which is a very high-yield topic both for USMLE staff exams and the clinical practice. Since a lot of patients you are going to see on wards and in outpatient settings will come having this disease. So let's get started. In this video, we're going to cover some definitions, pathophysiology, classifications, symptoms the patients experience, and also some diagnostic and treatment options for hypertension. Let's start with classifying hypertension. As we all know, we have two circulation types in our body, systemic circulation and lung circulation. The lung circulation has basically the task of bringing oxygen from the lungs to the blood, and this is the pulmonary circulation from the right side of the heart. And this is one location we can have high blood pressure in, which is a distinct topic and is not gonna be covered in this video since it's more of a poem topic. And another circulation part is systemic circulation, which brings the oxygenated blood to all the parts of our body and internal organs. And so when we have elevated blood pressure in our systemic circulation, we can classify it into two subtypes. The first one is the so-called essential hypertension, which is something most patients are going to have. We do not know the cause of this disease, but we call it primary hypertension since we cannot identify a real cause of this disease. The second type is secondary hypertension, secondary due to some disease, and we are going to cover some of the pathologic processes that can cause elevated blood pressure. For primary hypertension, even though we do not know the exact cause of this disease, we know some risk factors that contribute to the pathophysiology of this hypertension type. As in all cardiovascular diseases, we have modifiable and non-modifiable risk factors. The non-modifiable ones are obviously age due to chronic arterial stiffening with elevated calcium deposition in our arteries, which will result in isolated systolic hypertension because basically the blood that is getting pumped from the aorta has to work against these stiffened arteries. Another modifiable risk factor, which is not stated on the slide, is, for example, race and ethnicity, since there is some data showing, for example, Black patients having a higher risk profile for cardiovascular disease, including hypertension. Another risk factor is also the sex, because male patients tend to have higher risk for cardiovascular disease, including hypertension, and postmenopausal women losing their estrogen protection from cardiovascular disease also suffer from increased risk for this condition. Now let's talk about a little bit higher yield modifiable risk factors. This is obviously obesity, including low physical activity, because if you are obese, you are going to have a much higher amount of fat tissue that has to be perfused as any other tissue in our body. That will result in higher afterload. Let me show you that. Basically, you just have a lot more blood vessels, and when blood comes from your aorta, it has to work against all the resistance from these blood vessels, which will then result in higher afterload. Risk factor is smoking due to both nicotine-mediated vasoconstriction, which will also elevate afterload, and due to direct endothelial damage. Both other risk factor and another risk factor is basically a nutritional one. This is the high sodium intake, because if you consume a lot of sodium, your kidney will also have to resolve water to basically maintain the sodium concentration in our blood. Which will result in increased preload, which is basically the amount of fluid, the amount of blood our heart has to pump, which would then result in elevated blood pressure. Start talking about secondary hypertension, which is actually a much a much more rare form of hypertension. Only about 5 to 10% of the patients you have with elevated blood pressure are going to have secondary hypertension. And you have to be especially suspicious of this diagnosis if you have a treatment-resistant hypertension. We're going to discuss the definition of treatment-resistant disease a little bit later. But if you have a patient with poorly controlled hypertension and you find out that he's actually compliant with his treatment regimen, it is probably secondary hypertension, or at least there is some risk of that. Another clinical situation is hypertension in a young patient, otherwise healthy, without any risk factors for hypertension, including negative family history, but you still have elevated blood pressure. This is the time to run some tests to exclude some causes of secondary hypertension. So now let's start discussing the possible etiologies of the secondary hypertension. The first one is the Cushing syndrome, including Cushing disease, which is, as we all know, the state of elevated cortisol in our body. One of the functions of cortisol, which is a stress hormone, is to increase the density of alpha-1 receptors in our blood vessels. So basically, what we are having is, let me show you that. So basically, we just have much more alpha-1 receptors. So when we get some epinephrine or norepinephrine binding these receptors, we're gonna get an increase in afterload, which is the key factor for elevated blood pressure, because our heart will have to pump the blood against all this resistance caused by the increased density of alpha-1 receptors, which is just for the sake of review, are JQ coupled receptors, so you get just elevated calcium concentration in this cells, which will now result in constriction of the smooth muscle. And cause of secondary hypertension is the aldosterone axis. As we all know, aldosterone is the last element of the RAS cascade, which mostly acts on the collecting tube of the kidney, and that will result in the implantation of ENaC. So let's say this is an ENaC channel, and then we've got increased sodium resorption, which will inevitably draw water with itself, and which will result in potassium dumping out of the kidney. But this is the deciding factor, basically, aldosterone axis. There are several causes of aldosterone axis. For instance, the Con syndrome, which is basically an adrenal tumor in the zona glomerulosa, which will result in increased aldosterone production. It might be bilateral enlargement of the adrenal glands. So several causes. Another cause of secondary hypertension is something called OSAS, which is an obstructive sleep apnea syndrome. Because if you're sleeping and lacking oxygen all the time you're asleep, your sympathetic nervous system is gonna get activated, and it's gonna be activated all the time. And due to all this epinephrine, norepinephrine access, your blood vessels are going to be chronically constricted, which will then cause heart to pump harder, which will then cause elevated blood pressure. Another possible cause is pheochromocytoma, which is another type of adrenal tumor with increased epinephrine production. The patients are going to first experience some other symptoms, including episodic blood pressure elevations, tachycardia, headaches, flushing, sweating, all these symptoms of elevated sympathetic activity. Another possible symptom is something called corruption of the aorta. So this is something that would look like this. the best band, the best painter, but you basically get the the whole picture. So we've got the aorta, and just for the sake of the review, you've got the pre-ductal and post-ductal types. So this is in adult patients, is in an adult patient, this is usually a post-ductal type. And in this patient, you will get the elevated blood pressure in the arms if you measure them, if you measure blood pressure there, and decreased blood pressure with decreased perfusion in the legs, because due to this corruption, there's going to be just less blood flow for the lower part of the body. Another cause of secondary hypertension is hyperthyroidism. Actually, there are cases of hypothyroidic patients having elevated blood pressure, but just for the sake of pathophysiology and hyperthyroidism, you've got a state of elevated metabolic activity, including elevated blood pressure. The density of sodium potassium exchangers in our cells is going to be larger. There's going to be much more ATP needed. You get the picture. So the next thing I would like to discuss is the classification of patients coming with blood pressure, with elevated blood pressure. There are actually several stages of this disease. So there are actually many classifications. A lot of professional societies have different definitions of elevated blood pressure and hypertension, as we're talking about. Mostly USMLE, we're going to stick to American Heart Association, and this is something you're going to see in your boards, something you have to know. Normal hypertension is usually less than 120/80, elevated blood pressure, something about less than 130, and diastolic blood pressure less than 80. And if you have a patient with blood pressure over 130/80, it's gonna be hypertension stage 1, over 140/90 stage 2, and something called hypertensive crisis with extremely elevated blood pressure. But we're gonna come to this topic a bit later. It's important to know this classification because it is gonna partly guide your clinical management of the patient. And sometimes we're gonna see guidelines saying, okay, stage 1 drug to treat, stage 2 drugs to treat. For hypertensive crisis, there are actually some special drugs. So it's important to know the difference between different stages. Now, let's talk about something called hypertensive crisis. Here, there are also several definitions of this condition. The one I'm using is 180/110. Means hypertensive crisis, as we've seen on the last slide. There are some societies that use 120 for diastolic blood pressure. It's not that important. Just important to know if you have a systolic blood pressure over 180. It's not good. This is something you have to narrowly assess. You have to know two definitions: the definition of hypertensive urgency and hypertensive emergency. The difference between both those is a patient having an hypertensive emergency is going to experience some end organ damage, and we're going to cover some possible symptoms in the next slide. And if you have an asymptomatic patient, and most of patients having such a high blood pressure are going to be asymptomatic, you just have to really closely monitor them clinically, and you have to carefully examine them to exclude all the possible symptoms of end organ damage. Some other definitions that are important for STEPS and for WARD as well are actually hypertensive encephalopathy, which is hypertensive emergency with some CNS symptoms, including mental status changes, neurologic deficits, seizures, comas, all the CNS symptoms, and malignant hypertension, which is a little bit of a controversial term, means extremely elevated blood pressure with bilateral papillary edema, but we're gonna talk about ophthalmologic symptoms of hypertension on this slide. But let's just start reviewing some clinical features of hypertension for the cardiovascular disease. The heart has to pump against all this resistance. It's just gonna grow in size. It is also a risk factor. Hypertension is also a risk factor for coronary artery disease. And if we have the state of hypertensive emergency, some patients might present with myocardial infarction. I'm gonna highlight some conditions that might be typical for hypertensive emergency with RAD. For vascular complications, you have aortic dilation or dissection. Some patients with aortic dissection with this tearing pain, chest and back pain are gonna present with elevated blood pressure as well. And elevated blood pressure is also a risk factor for accelerated arteriosclerosis with stiffening of the blood vessels. For CNS, there is increased risk for TIA or transient ischemic attack, and for both types of strokes, ischemic and hemorrhagic ones. And you have to know for your step 2 exam mostly that hypertension is the single most important risk factor for stroke. It is hypertension. The stroke is also one of the things you might see in a patient with hypertensive emergency. And management of hypertension in such a patient is a bit more of an advanced topic, and we're not going to cover it in this video, but you have to be real careful with decreasing blood pressure, especially if a patient has an ischemic stroke. For renal disease, hypertension is a risk factor for both acute and chronic kidney injury, and even for end-stage renal disease. If you examine this patient, the blood of this patient, you are going to see something called azotemia, which is basically creatinine BUN elevation. If you examine their urine, you're gonna see an elevated number for albumin, basically protein, and you sometimes are even gonna see some blood in the urine. This is due to the narrowing of the something called afferent arteriole. Because if you have an elevated blood pressure, it's just gonna get thicker due to medial thickening, which will then worsen the blood supply of the kidney, which will then result in decreased GFR and decreased kidney function. And then the last system that is going to be affected for hypertension is the retina, and that might result in retinopathy due to decreased oxygen supply for the retina, papillary edema, which is basically the swelling and even vision loss if elevated blood pressure is not properly treated. So now let's talk about basically diagnosing hypertension, which is actually not that straightforward as you might think. As I've already mentioned, a lot of patients are not gonna experience any symptoms at all, and it is usually an accidental finding in an outpatient person who comes for their routine health visit, or just gets their blood pressure measured on some health marked, or I don't know what Walmart, whatever it is. But there are also actually some screening guidelines, because as you've seen, it is very important to properly treat hypertension to avoid all the complications I've already mentioned on the last slide. And the screening guidelines for the US say that you have to screen all the patients older than 40 years old at least once a year, and for younger patients, you have to assess their blood pressure and other cardiovascular risks factors at least once every 3 to 5 years, especially hypertension, as I've already said. If you're trying to diagnose hypertension, you mostly just do it with non-invasive blood pressure measurement with a blood pressure machine that you see at every doctor's office. And in order to be able to make this diagnosis, you need at least 2 readings on 2 separate occasions, because you are gonna be willing to exclude something called white coat hypertension or masked hypertension. If you have a patient with white coat hypertension, we're all familiar with these patients. They're so anxious at the doctor's office that their blood pressure is gonna skyrocket. Masked hypertension is a little bit more rare. You have a patient who comes to your office and has a totally normal blood pressure, but they're actually hypertensive at home or at work. You know what I mean. So sometimes you have to confirm this blood pressure with something called continuous blood pressure measurement or at-home measurements. But firstly, you have to educate the patient to get proper readings. There is also some additional testing recommended for newly diagnosed patients. So let's review that. Some of the studies are blood studies, including a complete blood count, basic metabolic panel, because we're gonna be willing to look at the red blood cell count to exclude something like polycythemia. For BMP, we're just gonna make sure there is no something like electrolyte derangement. You're also going to measure TSH to exclude some thyroid disease. You're gonna measure patients' glucose and HbA1c to make sure that they don't have diabetes, which is also a very important cardiovascular risk factor. You're gonna assess their kidney function with measuring creatinine, BUN, and GFR, and you're also gonna look at their lipid profile to exclude hypercholesterolemia in order to properly treat this patient. You're gonna examine their urine as well to assess the possible kidney damage. And you're also going to be willing to take a look at the heart with an ECG to pathology or left ventricular hypertrophy, something that might contribute to the risk profile of this patient. There are also some other tasks which might be ordered depending on the personalized risk profile of the patient, something like uric acid, liver function tests, or echo. Now let's talk about treatment. Our goal is to have a patient with a blood pressure less than 130/80, so that they are gonna be just below the threshold for stage 1 hypertension. We usually do not want to have a stricter blood pressure control in partially due to the risk of hypotension, and we actually, I don't know the patients to take like a lot of drugs to be in this range of less than 120/80. But this is a decision that is gonna be tailored to concrete patients, so we have to assess their arteriosclerotic cardiovascular disease risk to enable treatment goal. For every patient, you're gonna recommend non-pharmacologic treatment because it's usually cheaper. It's gonna influence all the other risk factors. It's something every patient with hypertension is gonna be educated on. The most effective measure is losing weight. Is actually losing weight. Very important to know for the boards. 20 pounds or 10 kilos lost, you're gonna get a decrease of blood pressure of about up to 20 millimeter of mercury. Another effective intervention is the DASH diet, which was going to result in a blood pressure drop of about 10. It is also important to limit the salt intake. Now let's take a look at the DASH diet, actually stands for diabetic approaches to stop hypertension. So it's basically just a healthy diet with a lot of fruits and veggies, a lot of white meats, and with the patient limiting red meats, sweets, sugar, salt, all the all the foods that are not very beneficial for their cardiovascular health. Now let's talk about pharmacologic treatment. It is very important to base the treatment regimen on the patient's comorbidities, basically other conditions. They come to your office. For example, for a patient with diabetes or chronic kidney injury, you're going to prescribe an ACE inhibitor or an ARB because those are drugs that are known for their nephroprotective properties. For Black patients or patients with isolated systolic blood pressure elevation, you're going to opt for thiazide diuretics or non-dihydropyridine CCBs, calcium channel blockers. Actually sounds the same as ACE. It's not right. It's same as thiazide diuretics. And those are the first line treatments for diabetes. Some second line options are beta blockers or aldosterone antagonists, for example, for patients with chronic heart failure, because those drugs are going to have cardioprotective properties, so the patients are going to profit from this treatment. If you're a patient with decompensation or their heart failure, you're going to use loop diuretics to decrease the preload and also to lower blood pressure as well, and some other drugs which are actually rarely used for hypertension only, or alpha-1 agonists, something like prazosin, or direct renin inhibitors, aliskiren. Those are not drugs typically used for management hypertension. We've already mentioned treatment-resistant hypertension. This is a clinical situation with a patient with a poor blood pressure control on 3 drugs, or with a blood pressure control with 4 drugs, which is a lot. And we're gonna have to, and we are actually willing to prescribe as few drugs as possible. So it's very important to educate the patient once again on the importance of sticking to their treatment. It's important to screen them for non-compliance. So we have to make sure they understand the time and the way they have to take their medication. If you have a patient with alcohol use disorder, you have to recommend them to reduce their alcohol consumption. In a smoker, you're going to recommend them to reduce or actually give up smoking at all. And only if all these measures are unsuccessful, you're going to consider a secondary cause that we've already discussed before. In a hypertensive emergency, you have to be very careful with the blood pressure stabilization, because you do not want to cause a drastic drop of the blood pressure. You just want to make sure all the organs are being adequately perfused, and some special drugs used for that are direct vasodilators such as hydralazine, some CCBs like nicardipine, clobidipine, and nitroprusside. For pregnant patients, it's very important to screen them for hypertension, because as we all know, some pregnant women are gonna get something called preeclampsia or even eclampsia with elevated blood pressure with end organ damage, which is an emergency for a pregnant woman. You have to properly treat hypertension if you find out this patient has this disease. And some special drugs, methyl-dopa, nicardipine, maybe clonidine, but those are those are special drugs for pregnant women. And the reason for that is a lot of drugs used for pharmacologic treatment are teratogenic, so they're dangerous for the baby. Drugs like ACE inhibitors or ARBs. So this is going to be the end of the video. I hope you enjoyed it. Leave your comments or questions if you have any in the comment section below. Thank you. See you next time.